Good evening, ladies and gentlemen. Welcome to the University of Cape Town, and welcome to the Faculty of Health Sciences and to this inaugural lecture. I'm the Deputy Vice-Chancellor Teaching and Learning, but this afternoon I'm Acting Vice-Chancellor. Dr. Price is away in Australia. So it is actually not all the things that one has to do when one is acting Vice-Chancellor are nice. Usually some are really awful. But inaugural lectures are something that I really treasure doing. All institutions like universities require rites and ceremonies that somehow have the ability of linking the past with what it is new. And that gives continuity to the intellectual enterprise that is supposed to be a university. So for me, it's a great honor to be in this situation in which the professoriate is actually welcome a new member of its college. And it is sort of saying to everybody that, yes, I do want to profess. And this is something that we do not always realize when we repeat these things day after day after day. But this is what makes us being who we are and what makes universities like the University of Cape Town stand where we stand. So this particular inaugural lecture also has a particularity, and it is that it is done under the auspice of the Office of the Vice-Chancellor. And this is so because the topic of the lecture is such that it can become accessible not only to academics but also to the broader public. So we are very, very happy to be here to listen to the inaugural lecture of Professor Crick Lund from the Department of Psychiatry and Mental Health, something that from all points of view we need very much in the country and in the world. So for those of you who are not familiar with the format of these ceremonies, after I finish speaking, the Dean of the Faculty, Professor Mayosi, will introduce Professor Lund. Then he will come to the podium and deliver his lecture, and then Prof. Jacobs would do the vote of thanks. Okay, so please enjoy yourselves. This is a very good show, so please switch off your cell phones. And Mungani, thank you very much.
Good evening, friends, colleagues, ladies and gentlemen. It is a particular pleasure for me to introduce one of our leading scholars in the Faculty of Health Sciences. But before I do so, I would like to acknowledge special people who are here with us in the audience this evening. Mr. Vernon Lund, the father of Crick, as well as his family, Justine Lund, as well as Sam and Jacob. We want to thank you for borrowing us Crick. And I was asking, when do you see him? Because he's almost always here, doing all the great work that he has done over the years. Now, Crick trained as a clinical psychologist at Rhodes and the University of Cape Town between 1995 and 1996. After completing his training, he took up a job with Professor Alan Fleischer, who was a psychiatrist in the UCT Department of Psychiatry and Mental Health. And that study that they did at the time was to develop the first post-apartheid norms and standards for mental health services in South Africa for the National Department of Health. On the strength of this work, the World Health Organization in 2000 invited Crick and Alan to collaborate in developing the WHO Mental Health Policy and Service Guidance Package. From 2000 to 2005, he worked with colleagues at the WHO and numerous countries to develop a range of mental health policy and planning tools. These have been used to guide mental health policy and service development in many countries. During this time, he completed his PhD titled Mental Health Service Norms in South Africa. In 2005, Alan Fleischer and Crick were awarded a DFID grant to study and develop mental health policy in 4 African countries. That project was called the Mental Health and Poverty Project. Crick returned to UCT and worked as a project manager and a principal investigator for the South African site on this MHAP study. As part of this study, he led a systematic review on the relationship between poverty and common mental disorders in low and middle-income countries. This study provided convincing evidence from 115 studies in 36 countries that common mental disorders are strongly associated with a range of poverty indicators in lower and middle-income countries. Subsequently, in the Lancet series on global mental health in 2011, he led a study that presented compelling evidence on interventions that break the cycle of poverty and mental illness in developing countries. Whilst working on the MHAP study, he collaborated with colleagues in the Department of Psychiatry and Mental Health here at UCT as well as at Stellenbosch to establish an inter-institutional center, the Center for Public Mental Health. He was appointed as its first director and served as a center director from 2010 to 2017. Following Professor Alan Fleischer's tragic death from leukemia in 2010, the center was renamed the Alan J. Fleischer Center for Public Mental Health. The center went on to be accredited as a UCT Research Committee Center in 2014 and a WHO Collaborating Center in 2015. Since 2011, Crick has led a collaborative mental health research hub on narrowing the treatment gap in sub-Saharan Africa, funded by the United States National Institute for Mental Health. He has been working with colleagues in Ethiopia, Ghana, Malawi, South Africa, Uganda, and Zimbabwe to advance this project called the AFFIRM Project, the African Focus on Intervention Research for Mental Health. As principal investigator of AFFIRM, he has led a randomized controlled trial of a low-cost task-sharing psychological therapy for maternal depression in South Africa. He is also a co-investigator on 4 other randomized trials on mental health interventions in primary care in South Africa and in Africa. Through this work, Crick has made major contributions to understanding the link between mental health and poverty, as well as interventions to address those issues. This has led to him being awarded several awards for his work, including the UCT's Vice-Chancellor's Award in 2010 and 2012, the UCT Health Sciences Faculty Top Soft-Funded Academic Research Staff Award, the Alan Pfeiffer Research Award of UCT, in recognition of outstanding research that demonstrates relevance in the advancement and welfare of South Africa's disadvantaged people. This was in 2014. And in 2015, he was awarded the T.W. Kambule National Science and Technology Forum Award for research and its outputs over a period of up to 15 years. This was work based on his PhD. He is a member of the Academy of Science of South Africa and has received the University of Cape Town College of Fellows Award in 2017. The success of many of his past and present research collaborations has been supported by strong collaborations with leading UK and US academic institutions, including King's College London, the London School of Hygiene and Tropical Medicine, Leeds University, the London School of Economics, Oxford University, Columbia University, and Johns Hopkins University. He has also forged strong collaborations with other African academic institutions, including Makerere in Uganda, Addis Ababa University in Ethiopia, at the University of Zimbabwe, the University of Malawi, University of Ghana, University of Ibadan, as well as the University of KwaZulu-Natal locally. In 2017, he was appointed on a part-time basis as a professor of global mental health at the Center for Global Mental Health at King's College in London. He now works part-time at UCT as well as part-time at King's College. But in fact, he probably spends more time in Cape Town than in King's College, which is our way of repatriating some of the resources from the north for work in the south. So, Crick, it is a pleasure to welcome you to present your inaugural lecture on 10 reasons to invest in population mental health in low and middle income countries. Crick. Yeah.
Hello, can you hear me? Yeah. Thank you very much, Mongani, for that very kind introduction. It's really a great pleasure to be here and a great honor, and really wonderful to see such a great turnout, so many friends and colleagues from all over the show and from various eras. So thank you so much for coming along. I've been told that the academic career follows a trajectory which begins at a point where the young academic knows very little about a large field of an inquiry, and during the course of the academic's career, they begin to learn more and more about a more narrow area, more focused area of inquiry. In other words, they learn more and more about less and less, until eventually they know a whole lot about nothing at all. And my understanding of the inaugural lecture is that it's meant to be timed shortly before that end stage. So I hope I'm not there yet. So I think I have about 45 minutes to summarize about 20 years of work, and my colleague Margie Schneider told me that's about 2.5 slides a year. So I'm going to try and work through this as quickly as I can. And here's an outline of my talk. I first want to just give a bit of background as to how I got involved in this business, and then set out some definitions which I hope will provide some kind of conceptual building blocks for this area of public mental health, which we are involved in. And then I want to share with you what I believe are 10 quite compelling reasons why policymakers in governments in low and middle income countries and also development agencies should invest in population mental health in low and middle income countries. I believe mental health is an issue which has long been neglected, but I also believe it's an issue whose time has come. And there's mounting global evidence and a growing global advocacy movement to give greater policy priority to mental health and to invest in and scale up mental health care across the life course. And then I'm going to conclude with a research agenda and spelling out some of the next steps for the field and with some acknowledgements. So here's a bit of how I got involved in this business. When I was training as a clinical psychologist in the mid-1990s, I was struck by 3 things. First of all, I was struck by the fact that the people who had the most needs for care often had the least access to care. Something I later came to know as the inverse care law. And it's a law that's often cited in public health, but not often cited in mental health. In other words, people who are exposed to adversity, who live in circumstances of poverty, have much higher risk for a whole range of mental health problems, and yet often can't afford or don't have access to mental health care. The second thing I noticed was that most service resources are concentrated in psychiatric hospitals. I did a lot of my training and my internship in a psychiatric hospital, and this is where we seem to train a lot of our psychiatrists and our psychologists, is in specialist tertiary hospitals. And I came to realize that you have to get really sick to get into a psychiatric hospital. You have to get really sick before you can get mental health care. And then the third thing that really struck me was that as psychologists, we are trained largely in individual long-term psychodynamic psychotherapy. And that's not to say that this can't be a helpful approach, but if we're trying to reach populations that need care, it may not be the most cost-effective approach. So I started to think about, well, how could these systems be organized differently? And after qualifying, I saw this job advertised to work as a research officer with Alan Flisher to develop the first norms and standards for mental health services. And I was lucky enough to get the job. And we did the first national situation analysis post-apartheid of mental health services. We went province to province. I was working with Lauren Muller. And We conducted surveys, so we got information, for example, about the number of psychiatrists per 100,000 population, as you can see in this map. I then did some work to develop a model for estimating the resource needs for a model mental health service for people with severe psychiatric conditions. And at the end of all of that, we submitted the report, and Alan said to me, "Why don't you turn what you did there into a PhD?" At first I didn't really think it was such a good idea. I wasn't that convinced at that stage that academia really had much of an impact on the real world as I saw it. And it was really only a couple of years later when WHO contacted us and said, "Well, could you come and share some of the work that you did, and would you work with us?" That I started to realize that this kind of arena actually can have a real impact on policy and services. And so much of my subsequent career has been trying to document current mental health service provision, mainly in African countries, contributing to mental health policy development, developing new service models and novel interventions, studying the social determinants of mental health and trying to understand more about the cycle of poverty and mental illness. And really, in a nutshell, trying to make the case for investing in population mental health across the life course. And so when I was thinking about a topic for this lecture, it really made sense that to make the case for why we should be investing more in mental health of populations. But before I get into that, let me begin with some definitions. So health is defined by the World Health Organization as a state of complete physical, mental, and mental is right in there, and social well-being, and not merely the absence of disease or infirmity. Mental health, on the other hand, has been defined as the capacity of thought, emotion, and behavior that enables every individual to realize their own potential in relation to their developmental stage, to cope with the normal stresses of life, to study or work productively and fruitfully, and to make a contribution to their community. In other words, it refers to the capacity or the capability of the brain to enable people to reach their full potential. And I think there's a lot in this definition which rings true and links with the work of people like Amartya Sen, who's been so influential in developing the capabilities approach that has informed much of what we currently see in development economics policy. Mental disorder, on the other hand, refers to disturbances of thought, emotion, behavior, and or relationships with others that lead to significant suffering and functional impairment in one or more major life activities. So it's much more than just everyday fluctuations in mood. It's a major disruption which causes significant suffering and interferes with a person's ability to perform their normal daily roles. And the main classification systems that we have for this are the WHO International Classification of Diseases and the DSM. Now these have been criticized, and I think there's a lot of movement recently to try and move towards a more dimensional approach to understanding mental health and mental illness along a continuum. Public mental health, then, is an approach in which the unit of analysis is a population or a community rather than an individual or a patient. And this is taken from work that John Parker and Rob Allen and I did. Nice to see them at the back today. In this article on Are We Training Our Psychiatrists Adequately as Public Mental Health Practitioners? So this approach leads the practitioner to analyze the way in which services are organized for a given population, to influence policies, plans, and budgets that inform service organization, to try and understand the ethical issues that underlie the allocation of resources. Why do we make the choices that we have about how we organize mental health services? To modify the role of the mental health specialist in the health system. In other words, not just to think about the mental health practitioner as somebody who provides individual clinical care, but also someone who can coordinate services and provide training and supervision for non-specialist health providers in the primary health care and the community settings. To use the best available research evidence to inform decision making, and also to strive towards equity in mental health care, including a primary health care approach to health systems. So when I teach public mental health to psychiatry registrars and intern psychologists, I often start by showing them a map of the Western Cape. And I ask them, what are the factors that drive population mental health in our province? And we talk about the wine industry and the DORP system and fetal alcohol syndrome. We talk about the tick epidemic on the Cape Flats. We talk about where do you go if you're psychotic and serious or suicidal and are, where do you find services? Where are most services concentrated? Why are they organized in the way that they are? Really to try and shift the focus from these training clinicians from only thinking about individual patients to try to think about systems and services and the population level factors that drive mental health and mental illness. So when we adopt this public mental health approach, I think we have an advantage because there are several tools at our disposal. Many of these tools are taken from public health. So we can measure the burden of mental disorders in populations by estimating prevalence and incidence. We have estimates now for disability-adjusted life years, which include years of life lost due to premature mortality and years lived with disability. And this measure, the DALYs, has really evened the playing field, making it possible to compare the burden of mental disorders, for example, with cancer and HIV, and allowing, hopefully, policymakers to make more equitable decisions about how resources are allocated. We can identify risk factors, protective factors. If we have longitudinal data sets, we can try and understand more about causal pathways and causal mechanisms. And we can document the cost of illness, including direct costs and indirect costs. Importantly, we can also not only document what is going on, we can also intervene. And we have a number of different study designs that we can use, including quasi-experimental designs, randomized control trials, implementation science. And these interventions can be directed at the general population to promote mental health among those who are well, to prevent mental illness among those who are at risk, and then also to provide treatment and rehabilitation interventions for people who are actually living with a mental illness. And what we see, if we look at trends in populations over time, is this is not a static group. People during the course of their lives will drift into or out of having a mental health problem of some kind or another. And these disorders vary across the life course in terms of their risk profile. Then this data can be synthesized using quantitative, qualitative methods, systematic reviews, and meta-analyses, and can then feed into policy development and policy implementation. So these are some of the tools and some of the conceptual building blocks of a public mental health approach. However, when it comes to trying to understand mental health in low and middle income countries, we're immediately faced with complexity. We have a number of complex social and cultural determinants which make it very difficult both to measure mental health problems but also to intervene. So these are pictures taken from Khayelitsha, which, as many of you know, is a large peri-urban township settlement just on the outskirts of Cape Town, not far from where we sit today. And it's marked, like many of the major urban slums of low and middle income countries, by high levels of poverty, food insecurity, inadequate housing, inadequate infrastructure. And for the last 6 years, we've been working in Khayelitsha, conducting a randomized controlled trial to evaluate a task-sharing intervention using non-specialist community health workers to deliver a psychological counseling intervention. And we've screened, to recruit for the trial, we screened over 5,000 women attending antenatal clinics. And we met many women, like this particular person, let's say her name is Nandi, who presented with all the classic symptoms of major depression. She had low mood, she'd withdrawn from many of her normal social activities, she wasn't sleeping well, not eating well, she was worried about the future. But when we inquired about her experience, we found that all of these symptoms, which we might identify in a diagnostic classification system, were really expressing themselves as a result of her experience of inadequate water and sanitation, poor housing. She was very aware of inequality. She couldn't help comparing her own circumstances with the circumstances of people who are much better off than her and who live not far away. She has regular or has been exposed to violence. She's insecure in her food. She's not employed, currently looking for work, and she's migrated to Cape Town from the rural Eastern Cape. So when we think about mental health in low and middle income countries, it's very difficult to disentangle mental health from their social and economic determinants. It's also very difficult to disentangle it from diverse cultural experiences of what we might call mental health problems. So that's a bit of background and a bit of context. I'd now like to jump on into these 10 reasons. So the first reason to invest in mental health in low and middle income countries is the simple reality of the burden of mental disorders. So as I mentioned, the Global Burden of Disease study, and the latest findings are from 1990 to 2015, allow us to document the burden of mental disorders in relation to other health conditions. And we see a very consistent trend in regions around the world of a growing burden of mental and substance use disorders. And this is being driven largely by epidemiological transitions and also demographic transitions. But there are also secular trends controlling for age and population size, which indicate increases in prevalence of some disorders. Also, when we look at the Global Burden of Disease study, we see that the distribution of mental disorders is not even across the life course. There's a spike in adolescence and early adulthood, which places young people at particular risk, especially for conditions like depression, anxiety, and substance use. And this is a critical developmental stage which often sets a trajectory for lifelong development and economic productivity. So if we're going to think about intervening in populations, we need to think about intervening early. We need to think about intervening in pregnancy, infancy, childhood, and adolescence. And unlike many other non-communicable diseases, which are presented largely in midlife and later life, many mental health problems present themselves early in life. The second reason to invest in mental health care is that there's quite simply no health without mental health. You may be surprised to know that the brain is actually connected to the rest of the body and presents itself in quite complex ways. For example, in relation to HIV, people with mental disorders are at increased risk of contracting HIV, but it also works the other way around. People living with HIV have a twofold risk of depression compared to the general population. And adherence to antiretroviral therapy is adversely affected by conditions like depression and alcohol use disorders. Also, we know that treating depression using antidepressants not only improves adherence to antiretrovirals, but actually also improves a CD4 count and immune system functioning. And HIV-associated neurocognitive disorder among patients commencing ART in Cape Town has been found to be particularly high, and this is work conducted by my colleague John Joska here in Cape Town. This whole thing of no health without mental health also extends to non-communicable diseases. These are the baseline findings from a trial that was led by Lara Farrell, who's also in the audience today, looking at developing integrated primary care guidelines for nurses for non-communicable diseases. And we did a large cluster randomized controlled trial in the Eden district. And what you see here is a high level of multimorbidity. If you look at the bottom right-hand corner, square, you can see that in the depression group, which comprised around 2,500 individuals, only 20% had depression alone. The remaining 80% had depression comorbid with other chronic non-communicable diseases. And then, of course, mental health has a major bearing on maternal health and child health. We know from the latest pooled prevalence estimates that the prevalence of both antenatal and postnatal depression in low and middle income countries is around 19 to 20%. But in high income countries, it's just around 9%. So you have an almost twofold risk of developing perinatal depression if you're a woman living in a low and middle income country compared to living in a high income country. And the consequences have now been quite well documented, and they include low birth weight, suboptimal mother-infant bonding, inadequate childcare, and impairments in behavioral, social, emotional, cognitive, and physical child development, extended up to children aged 10 years old in one longitudinal study from South Africa. The third reason to invest in population mental health is, despite this massive burden and despite the high level of comorbidity with other health conditions and the opportunities for providing treatments for mental health, which would also improve other health outcomes, there's a major lack of policy commitment and resources. And this leads to what we know as the treatment gap. So these are figures from the latest WHO Mental Health Atlas, which is a survey of mental health resources and services around the world, currently conducted every 3 or 4 years. And we see mental health expenditure per capita in high-income countries is around $58 per person, and in lower middle-income countries it's about $1.53. And this is reflected in the way the mental health workforce is distributed globally as well. So we see that we have around 52 mental health workers per 100,000 population in high-income countries, but less than 1 per 100,000 population in low and middle-income countries. There's around 1 psychiatrist for every 2 million people in sub-Saharan Africa. And it gets a little bit worse than that, because not only are there less resources in low and middle-income countries, but most of the resources that do exist are concentrated in psychiatric hospitals. You can see in this graph, in low and middle-income or lower middle-income countries, most of the resources are concentrated in psychiatric hospitals, whereas in high-income countries there's a much more even distribution of resources between psychiatric hospitals, general medical settings, and primary care settings. So Mark Tomlinson, I'm pleased Mark is here tonight, I think somewhere. We've done some very nice work looking at why is mental health not given greater policy priority, and we adapted the Schiffman and Smith framework, which had looked at neonatal policy to try and understand some of the key characteristics which have driven significant investment in health conditions. And 3 key things stand out. One is commitment by political leaders. Secondly, formalization of mental health, or whatever the health condition is, in national government policy. And then thirdly, resources that follow the policy. And in most of our countries, we might have some policy commitment, but we have very little clear leadership and even less resources to follow. And this leads to a massive treatment gap. This refers to the proportion of people who live with a mental health problem who actually receive any form of evidence-based care. And on average, from the World Mental Health Surveys, we know that about 75% of people who live with a mental health problem don't receive any form of evidence-based care. That's very consistent with South Africa from the SASH study, which Dan Stein and others have led. In countries like Ethiopia, it's in excess of 90% of people with severe mental illness who receive no care. Right, reason 4 is the social and economic costs of mental illness. So we know that mental health problems have a major social impact, and this is measured by something called days out of role. And Sumaya Mall, who was a postdoc student in our center for a couple of years, now based at Wits, and I see Sumaya's dad is with us at the back, published this very nice paper on days out of role due to mental and physical illness from the SASH study as well. We found that anxiety disorders and depression were associated with the highest days out of role, around 28.2 and 27.2 days per year respectively, out of all mental and physical illnesses. And comorbidity, again, was very common. We did some further analysis of the SASH database to look at lost earnings associated with mental illness. So we compared people with a mental illness with those without in the sample and looked at their earnings and found mean estimated lost earnings of around $4,800 per adult per annum. And when we projected that to the total cost to society, we estimated that it cost around $3.6 billion in 2002, which is when the year this study was conducted. And what's really interesting is that this completely dwarfs direct spending on mental health care, which in that year, or in 2005, was around 59 million. In other words, it's costing society more to not treat mental health problems than to treat them. And this, I believe, is another very compelling argument to invest in mental health care. The 5th reason is that there is a complex cycle of poverty and mental illness, which maintains both poverty and mental illness. And this has been increasingly recognized. The WHO conducted a commission on the social determinants of health, and in 2010 published this report, Equity, Social Determinants and Public Health Programs. And we published a chapter in there, myself and Vikram Patel and Alan Flischer, on the social determinants of attention deficit hyperactivity disorder and depression. Really, again, providing quite compelling evidence that social adversity is a major risk factor for these conditions. In the same year, the WHO published this mental health and development report. This was an output of our mental health and poverty project, and really made quite a compelling argument for why we should be targeting people with mental health problems in low and middle income countries as a vulnerable population who merit targeted development assistance. And in the same year, the UN General Assembly Declaration cited this report. And then more recently, the Gulbenkian Foundation, which Marion has been very involved with, published this very nice overview of the social determinants of mental health. Well worth reading if you're interested. Around that same time, as part of the Mental Health and Poverty Project, we published this large systematic review. It was the first of its kind to look at the association between common mental disorders and poverty. It was an exhaustive, and I have to say quite exhausting process. We found 115 studies after screening thousands and thousands of abstracts in 36 countries, which provided very compelling evidence that both in bivariate and multivariate analyses, there's a statistically significant association between poverty and common mental disorders like depression and anxiety and somatoform disorders. And poverty was not only associated with increased prevalence, but also with more severe conditions, longer course, and worse outcome. Now, the big challenge when we think about the relationship between poverty and mental health is trying to understand causality. Because at a very basic level, are people depressed because they're poor or poor because they're depressed, or both? And so based on the limited number of longitudinal studies that we did find and other intervention studies, we put together this framework, which is really trying to understand the cycle of poverty and mental illness. If we understand poverty as being marked by these conditions, broadly defined, these conditions increase risk for mental illness through what is referred to as the social causation pathway. Why? Because experiencing poverty leads to social exclusion. It leads to high levels of day-to-day stress and worry about food insecurity, reduced access to a social capital or a safety net, malnutrition, obstetric risks, violence and trauma. All of these things increase risk for mental illness and lead to poor care, lack of care, and a more severe course. But the relationship also works in the other direction as well. So people who are living with a mental illness tend to drift into or remain in poverty during the course of their lives because they spend more on health care, they are more disabled by their conditions, and so they're less likely to be employed or to be economically productive. And often stigma excludes them from income-generating opportunities. And so this cycle grinds on from generation to generation. The big question, which has also interested a number of investigators in this field, is which particular disorders do these pathways apply to? And in a classic paper published in Science in 1992 by Bruce Dorenvent and colleagues, they showed that the social causation pathways seem to be a better fit for conditions like depression, whereas the social drift pathway seemed to apply more readily to schizophrenia. So I became really interested in this and wanted to understand more about how we might measure this. And I worked with a fantastic statistician called Anibale Coes, I'm not sure if he's here today, from the School of Public Health here at UCT, who taught me a whole lot about structural equation modeling. And what it enables you to do is to construct a latent variable for depression and a latent variable for, in our case, assets at both the household level and the individual level, and then estimate the effect of depression and assets at time 1 on the converse. In other words, the effect of depression on household and individual assets at time 2, the effect of household and individual assets at time 1 on depression at time 2. And essentially, this is testing the social drift pathway, and this is testing the social causation pathway. And what we found, using standardized linear regression coefficients, so we were able to compare the relative contribution of each, we found that both are actually happening simultaneously. The effect of the social causation was around twice that of social drift, but nevertheless, social drift was also statistically significant. So I think this provides really compelling evidence that if we are to try and break these cycles, we really need to intervene both by providing mental health care and also providing development assistance in the form of social grants or financial social security. We've done some further analysis of household dynamics in this area, and Sumaya Dokrat is here in the audience as well, has done an amazing job with analyzing this very large and complex data set from the Emerald study. And we compared households living with somebody who has a mental, neurological, or substance use disorder with households who have someone in their house who just happened to go along to the primary care clinic on the day that we were recruiting but didn't meet the criteria for an M&S disorder. And the bit to look at is the blue bars in each country, so 6 countries involved. The blue bar represents non-case households, and the purple bar is all cases. And you see the figures for specific disorders in the other colors. What this measures is the proportion of households who report using at least one cost minimization strategy. This refers to strategies to cope with economic adversity, like withdrawing children from school, taking out loans, cutting down on food to make it through the day. So these are very regressive financial coping strategies which entrench poverty also on an intergenerational level. Again, making quite a compelling argument for why people and households living with mental illness really deserve development assistance. We've also done some further work looking at this cycle of poverty and mental illness by not only reviewing descriptive studies, but also looking at intervention studies. And as part of the 2011 Lancet series on global mental health, we published this paper, which includes 2 systematic reviews. So in the first review, we looked at financial poverty alleviation interventions, like cash transfers, loans, and asset promotion, which assessed mental health outcomes. In other words, does providing basic poverty alleviation improve your mental health? And there were some fascinating studies, one from the Oportunidades program in Mexico, which showed that providing social grants to households reduced salivary cortisol as a proxy for stress in children aged 3 to 6. So even children at a very visceral level experience financial stress. But it was something of a mixed picture. So loans actually didn't feature that well. And in fact, they seemed to increase stress. So for those of you who are thinking of taking out a loan, you might want to reconsider. Not good for your mental health. But on the other hand, when we looked at standard mental health interventions, for example, group or individual psychotherapy, psychiatric medication, community rehab programs, and so on, which had evaluated economic impacts, we found actually quite a compelling story, which was that where these interventions showed clinical improvements, they also found economic improvements. And these extended not only to the individual level, but also to the household level. We're now busy taking this further with a much larger and updated systematic review and meta-analysis, which Tundi Davies is helping me with. I think she's somewhere in the audience as well. And we found 32 randomized controlled trials now and are doing a large meta-analysis with colleagues in Oxford, which we're hoping to write up soon. Okay, the 6th reason for investing in mental health care is the human rights argument. And I think this is an argument which really stands on its own, and we could do a whole talk on this. People who live with mental illness are subjected to human rights abuses in countries and cultures around the world. And these are widespread not only in communities, but also in psychiatric institutions. Common practices are chainings, cages. These are very widespread in West Africa. There's a whole campaign running at the moment to try and release people from chains and provide care for people living with schizophrenia, epilepsy, and bipolar disorder in several West African countries. There are a number of human rights protection instruments which we know of, which are implemented to varying degrees. The UN Convention on the Rights of Persons with Disability, which was adopted by many countries around the world in 2007, I think is one of the main advocacy tools in this arena. And WHO have also developed mental health legislation and human rights guidelines. And there's a wonderful project for those of you who are interested, led by Michelle Funk at WHO, called the WHO Quality Rights Program, where they're working in psychiatric institutions in a number of countries to try and look at best practice, least restrictive forms of care, and trying to reduce human rights abuses. In South Africa, tragically, we've seen a recent example of this with the Life Esidimeni case. In 2015, the MSc for Health in Gauteng, MEC Mahlangu, took the decision to close a 2,000-bed facility called Life Esidimeni, and patients were discharged into unlicensed and under-resourced NGOs, and as I'm sure many of you know, around 140 people died during the course of the ensuing 6 or 8 months. And I think this has quite rightly provoked a massive public outcry and brought a lot of public attention to the issue of mental health. And I think there are several measures being put in place, among them to try and implement our mental health policy, which was adopted in 2013, and if it had been properly implemented, Life Esidimeni would never have happened. The seventh reason why we should be investing more in mental health is that I believe there's strong links between mental health and the Sustainable Development Goals. So here's Ban Ki-moon at the launch of the SDGs in September 2015, and he says, "We have a big, bold agenda before us. Now we must work to make it real in people's lives." And it really is a super big, bold agenda. By 2030, we will have no poverty, zero hunger, good health and well-being, quality education, all of these wonderful things. And there's a huge amount of work being done by UN and other development agencies to put in place indicators to measure countries' progress towards achieving these goals. The good news for mental health is that for the first time, mental health is included. It's actually mentioned in SDG 3, which is all about good health and well-being. It says in Target 3.4, by 2030, reduce by 1/3 premature mortality from non-communicable diseases through prevention and treatment, and promote mental health and well-being. And then also in Target 3.5, strengthen the prevention and treatment of substance abuse, including narcotic drug abuse and harmful use of alcohol. So these commitments are already critical for moving towards universal health coverage and making sure that mental health is included in core packages of services. And for example, in South Africa, as we move towards the NHI, I believe it's vitally important that we advocate strongly for mental health to be included in those core funded mandates. But this, for me, raises another question, which is, what about the social determinants of mental health? I've spoken earlier about poverty and how it drives mental health problems. What about all of these other goals? Aren't they also relevant for mental health? And in many ways, I think one could argue that they are all relevant in one way or another. And with that in mind, we undertook a major systematic review as part of the Lancet Commission on Global Mental Health and Sustainable Development, which will be published in September this year, to review the evidence on the social determinants of mental health and to link these with the Sustainable Development Goals. And we developed this framework, which basically categorizes social determinants of mental health into demographic, economic, neighborhood, environmental events, and social and cultural domains. And you can see each domain has distal factors and proximal factors. So the distal factors are often mediated by proximal factors, and they have an effect on the mental health of populations across the life course from infancy to old age. And what we did was we identified the SDGs which we thought were most relevant for each of these domains. And we reviewed the evidence. So we have in the online appendices to this paper summaries from the 268 review articles that were included in this review, summarizing all of this evidence. And then in the final table of the paper, we present what we think are the likely mechanisms by which they act and what are current best practice interventions which might affect these social determinants. I think this is a really important piece of the puzzle. I don't think we can only scale up mental health care. We can't treat people and then send them back to the conditions that made them sick in the first place. And so we need to think about the social determinants of mental health and how we intervene at this level. And so the challenge, I think, is really to try and demonstrate the link between these upstream sustainable development goals and mental health benefits. In a sense, can we also show that providing mental health care yields social and economic and environmental benefits, and is mental health both a means and an end of development? Okay, reason 8. The good thing about a talk with numbers in it is you know when it's coming to an end, right? So reason 8 is that policy planning and legislation guidelines and tools are available. So countries can't say, we don't know what to do. There are documents, they are free, they can be downloaded from the internet. These are the modules of the WHO Mental Health Policy and Service Guidance Package, which I worked on with a number of other colleagues over 2000 to 2005. They provide very practical step-by-step guidelines. How do you go about developing a national mental health policy? How do you develop a national mental health plan? What should be the optimal service mix for services? How do we design information systems? How do we finance mental health services, and so on? And they're nice and colorful, easy to read, so read away. The good thing is that we have seen some progress as a result of some of this work. So in 2001, less than 50% of African countries had a mental health policy. And now in the latest WHO Atlas data, we see that around 71% of countries now have a national mental health policy in sub-Saharan Africa. So there's signs of progress, which is very encouraging. And we also have mental health service frameworks, such as this, which is in the WHO guidance package materials. And this also has found its way into a number of national mental health policies, including our own here in South Africa. And what it shows is essentially, instead of the top-down approach, which I was speaking about earlier on, where most of the resources are concentrated in psychiatric hospitals, we need to be investing in community mental health care, primary care services for mental health, and then integrating psychiatric services in general hospitals and having specialist community outreach teams while providing information about self-care and promoting mental health in the general population. And what we see from this framework is that as you go up the pyramid, the costs increase, but the frequency of need in a given population generally decreases. Right, reason 9 is that we have cost-effective interventions and low-cost service models. And it's been a real pleasure since 2011 to work on the PRIME consortium. PRIME stands for the Program for Improving Mental Health Care. And it's great to have some people who've been involved with that, Inge Peterson, Arvin Barner, and Lara Farrell, who lead the South African site of PRIME. We lead this consortium from here at UCT, and we subcontract to research institutions in each country. So in each country, there's a research team, and they have established a memorandum of understanding with the Ministry of Health and established a district demonstration site where we have developed district-level mental health care plans and implemented them over a 3 to 4 year period, and now scaling them up to other districts. And that's been enabled through often mobilization of additional funding. So for example, Inge and her team have raised funds from the Center for Disease Control to take the PRIME model, which has been developed in the Dr. Kenneth Kaunda district in the Northwest Province, to other provinces, now in Amajuba in KwaZulu-Natal and in Ehlanzeni in Mpumalanga. This is the overall framework for the district mental health care plans. And very importantly, it's not about just training primary healthcare workers. It's about strengthening the healthcare organization and developing interventions at the community level to raise awareness, improve detection, improve access to treatment, promote recovery, and then put in place enabling systems that allow all of this to happen. And we've implemented these mental health care plans in 37 facilities across 5 countries and provided care to over 20,000 mental health visits. And we're evaluating these. Each of these districts has really been a kind of laboratory where we've used case studies to document how well the mental health care plan was implemented, repeat facility detection surveys to assess changes in the capacity of primary care workers to detect common problems like depression and alcohol use disorders. We've conducted cohort studies tracking people who receive care in these districts over a 12-month period. And Emily Barron, who works in our center, has been leading that analysis for PRIME. to see if these mental health care plans have an impact on clinical functioning and economic outcomes among people who receive care. And then we've also conducted repeat community surveys to assess whether we have an impact at the population level on treatment coverage. And this for me is all about the how question. So we have these two mathematicians working on a complex problem, and then they say, then a miracle occurs, and this guy says, I think you should be more explicit here in step 2. It's all very well to advocate for scaling up mental health care, but the devil really is in the detail, you know. And I wanted to just acknowledge the Prime Project Manager, Erica Breuer, who's just submitted her PhD on this approach called theory of change, which is a way of mapping out the causal pathway from entry into a system to the desired outcome, and really allows one to interrogate the detail of what your assumptions are in the implementation process. Also in the line of trying to build the evidence base for interventions, we've been working since 2011 on the AFFIRM study, which is the Africa Focus on Intervention Research for Mental Health. And this has been involved research sites in South Africa and Ethiopia, and also capacity development in the form of fellowships for our MPhil program in public mental health in Zimbabwe, Malawi, Uganda, Ethiopia, and Ghana. And as part of this work, we've conducted the randomized control trial that I mentioned earlier on in Khayelitsha, assessing the cost effectiveness of a task-sharing intervention using non-specialist community health workers. We're in the process of writing this up at the moment. This is something that I have in my inbox to do, and we have the analysis already. Disappointingly, we found in this particular trial a non-significant, although small effect, showing that the intervention, the counseling intervention, did reduce depression scores on the Hamilton Depression Rating Scale from around 15 at baseline antenatally to around 9 at 3 months postnatal. The difference becomes significant over time. So at 12 months, the women in the intervention arm were significantly less depressed than in the control arm, but the effect size is quite small. And I think it's very important that we try and understand our failures as well as our successes. There's been a lot of advocacy for task-sharing models in low and middle-income countries. In our particular case, we found only a small effect. And so we need to look in detail at the process data to look at what happened and how this happened. Part of the reason is that the control arm were also contacted 3 times and given supported telephone calls. And that alone seems to have had some beneficial effect. I think the other thing is that we gave relatively brief training for the community health workers, which we thought was in line with what is a scalable model. But I think learning from this, we should be training our community health workers and non-specialists for much longer periods of time and paying greater attention to fidelity in the implementation. Thankfully, this is an exceptional study because, as you can see from this meta-analysis conducted by Daisy Singler and colleagues in 2017, this is a review of some 27 randomized controlled trials in low and middle income countries which have used non-specialists to provide psychological therapies. And they found a pooled effect size of 0.49, which is really quite remarkable considering that it's using non-specialists. So low-cost, effective interventions are available. Reason 10 is that not only does it make sense to invest in mental health care because of the clinical benefits, there are also good economic reasons to do so. And my friend and colleague from WHO, Dan Chisholm, has done this wonderful study. It's a return on investment analysis. He reviewed the evidence for best practice interventions for depression and anxiety and looked at improvements in labor force participation as a result of these interventions, and estimated that for the period of the Sustainable Development Goals from 2015, a $1 investment in mental health care would yield a $2.3 to $3 return on investment for economic benefits alone, and up to a $5.7 return on investment if we include health benefits. So that's a pretty good return on investment. Very encouragingly, the World Bank and the WHO hosted this meeting in April 2016. And here's the president of the World Bank, Jim Kim, the Director General of WHO, Margaret Chan, all saying mental health needs to be made a global development priority. So not just a health issue, a development issue. And it should be taken out of the shadows. So very encouraging. Right, I know I'm just about over time, so what are the next steps for the field? Well, I think we really need to understand more about the dynamics of how poverty and mental illness are transmitted intergenerationally, to understand more about the mechanisms of poverty and mental health over time, the links between gender, poverty, and mental health across the life course, and the links between genetic, biological, and socioeconomic risk factors. And this means longitudinal studies with large data sets that are adequately powered. And this is something that we really are lacking, especially in sub-Saharan Africa. We also need to conduct intervention studies targeting specific mechanisms, both distal and proximal mechanisms. So some ideas are combining cash transfers with psychological interventions and testing the effects not only of each, but also their interactions over time. And testing the impact of improving living environments for vulnerable populations. So this requires linking cognitive neuroscience with behavioral economics, and I think there's lots of exciting potential here. There's also opportunities for piggybacking studies on other initiatives. So JPAL, for example, has conducted a large number of poverty alleviation and violence prevention trials in low and middle income countries. So we should be adding mental health outcomes to these. And we should also be adding economic and intimate partner violence outcome measures to mental health trials. In fact, in a new initiative that we're conducting called the Econ IPV MH study, we will be reaching out to trials in the coming months to ask them whether they would consider adding economic and intimate partner violence measures to their mental health trials. And then the key question is who should fund these? And I believe it really is on international development agencies as well as governments to contribute and commit substantial new funding. There's a proposal at the moment for a global partnership in mental health, and Vikram Patel has been driving a lot of this work. And as part of the Lancet Commission on Global Mental Health and Sustainable Development, we're hoping that there will be support for a global fund which will mobilize some of these resources. And we really need implementation science. The research agenda needs to continue as we see more investment in scaling up. And who should deliver? Well, I think it's all of us, really. It's not just up to mental health specialists. It's development practitioners. It's people living with psychosocial disabilities. It's nothing about us without us. All family members, we all need to contribute to a coordinated multi-sectoral approach to address both social causation and social drift pathways. So I want to conclude by just a few acknowledgements, and if you'll just bear with me for an additional few minutes. Because all of this work is really a team game, and I'm very lucky to work with a wonderful center, the Center for Public Mental Health. This is us at one of our annual picnics a couple of years ago, and it's just an incredibly dynamic and fantastic group of people. I really look forward to going to work every day with this bunch of guys. And I don't have time to name everyone, but I particularly wanted to acknowledge Catherine Sorsdahl and Ashraf Kaji, who've now taken over direction of the center from me, and Margie Schneider, who's Deputy Director. Also want to acknowledge Simone Honigman, who leads the Perinatal Mental Health Project, and Sally Field for the wonderful work that they do. And Leslie Swartz, who's sort of hovering over us there like a benevolent grandfather or godfather, who's really been one of the drivers of this. He first planted the seed of this idea way back when. And then I want to acknowledge and thank members of the UCT Department of Psychiatry and Mental Health, which has been my home since 2005 and even before that. Especially, of course, Alan Flischer, who really encouraged me. And I think I certainly wouldn't be doing what I'm doing now if it wasn't for him. And it's really mentors like him. And I think he's had a huge influence on a number of people in this room. So just a amazing person. I also wanted to thank Professor Dan Stein, who's our head of department, who's been a fantastic support for all of my work and for our center's work. He encouraged us to establish a division of public mental health in the department and has really been incredibly supportive of all of our work. And then a number of people in the department, both in the division of public mental health and friends. It's really just an amazing group. So I just wanted to acknowledge and thank all of them. And especially these two guys. This is Willem de Jager, who's a child psychologist in the department, and Andrew Carlisle. I put him in there because he used to work in the department, but these are my surfing buddies. So Also wanted to thank and acknowledge the amazing array of people from countries around the world. I'm really very privileged to be plugged into this network. And there's a real sense of community. When we meet at meetings, it's like seeing old friends. And these include people in a range of different universities, NGOs, government positions. I don't have time, I think, to name everybody, but really just a wonderful network. Particularly want to acknowledge Vikram Patel, who's based some of the time in India, but really is kind of everywhere. He's all over the place. Currently based in Harvard, and also colleagues at King's College London, Martin Prince and Graham Thornycroft, who've been incredibly supportive. And then funders, without whom none of this, of course, would be possible, especially the Department for International Development in the UK, which has funded our work since 2005. And then I wanted to also take this opportunity to thank and acknowledge my amazing parents, Vernon and Judy Lund. They turned 80 this year, and this is them, still in love as ever. Amazing. So my mum turned 80 in March this year, and we all had a nice family gathering. And my dad is about to turn 80 in June, and he's here with us tonight, so really a great pleasure. And then these three guys who are just amazing. This is my amazing wife, Justine, and Sam and Jacob. I really think a lot of what I do wouldn't be possible without this incredible woman, Justine Evans. And I think it's no coincidence that she and I were married 20 years ago when my career really started getting going. She's an incredible source of unequivocal support, care, and love. And I just wanted to acknowledge all that she's done to make this possible. So thank you so much, and we look forward to having some drinks with you afterwards. Thank you.
Well done.
That's it, man. Thanks, man.
Thank you very much. Prof. Jacobs, would you like to do the vote of thanks?
Good evening, everybody. It's wonderful to see so many people from Crick's life and from the mental health world here. There are young professors and old professors. I see Brian Robertson here. There are emeritus people like Andy Dawes and the younger people. Over here, we have Michael Jackson in the front row. So I just wanted to say, Crick, it's a tribute to you that so many people have come tonight, and from all the institutions in the Western Cape and beyond. So I really wanted to thank you for an absolutely brilliant exposition of public mental health, its importance nationally on the African continent and globally, and for reminding us of the critical need to continue to address the social and economic determinants of health, as well as the policies, programs, and practices which have the potential to address the inequities in global mental health, with the target always being on the poorest of the poor in low and middle income countries. So your own contribution to the mission of public mental health has been pursued relentlessly, and those of us who know you know what you've done over the last 20 years, and Justine can attest to that. And with the highest order of academic rigor, with the high impact factor journals, extensive publications, but you didn't end there. You actually made sure that you had a sustained commitment to making sure that your efforts not only get shared like that in the scientific media, but especially in places where it matters, and particularly in public policies for mental health. So the Dean has expressed that so eloquently, your career. And I know that both the faculty and the university at large not only appreciate the road that brought you here tonight, but appreciate the fact that you stayed. And we are all very glad of that. I'd like to think of your pursuit of an exceptional career, which is focused on addressing, which was once an orphan discipline, and thanks to you and others, no longer orphaned, public mental health. And also the most marginalized and mostly voiceless. And I like to think that was inspired many years ago when, as a conscientious objector to the military service of the apartheid government, you chose to come and work where you live now at the Children's Center. And there you met children with neurodevelopmental challenges in the Childcare Information Center. And you met the children in the Teaching and Learning Center who also have psychiatric illnesses. And now you're back at that campus. And I think we're all so grateful to you for having chosen to work with children's mental health rather than going into the army. It's clearly augured well for what was to come. But time moved on over the years, and over almost 3 decades, and your colleagues from here, some of whom are here tonight, and from all around the world, have huge appreciation for your achievements and contribution. So here's what they say to thank you, and they say it much better than I can do. So starting with John Joska, your current head of department. He expresses his appreciation for your significant role in bringing such credit to the Department of Psychiatry and Mental Health through your academic distinction, but also through your role in forging greater links with the broader public health sector, and particularly with the post-apartheid national government as it was formulating policies and plans for mental health. And I have no doubt that Dan Stein, who's come out of sabbatical to be here tonight, and also Melvin Freeman, who no longer serves in the National Department of Health, sadly, will agree with that, will agree with John. So from your other newer home, King's College in London, Graham Thornycroft is on an aircraft tonight from India to here, and he's deeply disappointed that he can't be here. But he commends you, and I quote, as an outstanding scientist and a superb collaborator. He says, in my work with him in recent years, for example, in the context of Affirm, Prime, and other projects, I've become aware that Crick is a gifted leader, a clear and fluent writer, an inspiring teacher and communicator, and a scientist of important and original ideas. On behalf of King's College London, he says, I'm delighted to send this message of sincere appreciation for Crick and his vital work for global mental health. And Martin Price, who I believe is your boss now. He concurs, and he adds, your contribution to mental health in South and Sub-Saharan Africa has been immense. It's been my pleasure and privilege to learn much from your leadership, from the many collaborations that UCT and King's College have shared. Now, you embody the link between our two institutions. And he goes on to say, we are delighted to have you on board as a King's professor, too, safe in the knowledge that this will only strengthen the collaboration and invigorate your continuing efforts for mental health for all in Africa. He says, I always knew that you were an exceptional talent, but now the Royal Society and the UK Home Office have confirmed this. Your Tier 1 visa, putting you in the same league, although not literally, as the international football stars at Manchester City and Chelsea. And for the Arsenal, this to say. We are grateful to Crick for not only building and consolidating the centre, but for his collegiality, warmth, and commitment to making the centre a truly collaborative effort between UCT and Stellenbosch University. He has managed to create a warm and friendly work environment where not only do we look forward to coming to work every day, as you said you do, but also feel mentored, valued, and privileged to be able to contribute to public mental health in South Africa and internationally. Leslie Schwartz, the grandfather, yeah? I'll tell him what you said there. He regrets that he can't be here tonight because I think he's delivering a lecture, not an inaugural. He's a lifelong, I know that he's your lifelong colleague, and he's now at Stellenbosch University, and he's also Alan Fisher's co-birth parent of the concept of the Center for Public Mental Health. And he adds, Crick has been the most supportive and inspirational leader. He knows how to listen and help others to find their own strengths, and that's Amandla in my words, in my world. And so back to the global stage. Shekhar Saxena is Director of Mental Health at WHO, sadly retiring at the end of June. And he notes that public mental health is increasingly a high priority for WHO, and the role that Professor Crick Lund has played in the last many years has contributed very substantially to WHO's efforts in capacity building in Africa and globally, including as head of its collaborating center at UCT. WHO looks forward to working even more closely with him while wishing him all the best in his new role. And another collaborator, Oloyinka Omigboton, who is the professor and head of the Department of Psychiatry at Ibadan, says his expertise on mental health economics as well as public mental health policies and organization of services has been a source of inspiration to mental health professionals on the African continent. And she adds, he's currently supervising a PhD candidate from Nigeria, Jibril Abdul Malik, on the economics of mental health care in Nigeria. And he has this to say about Crick. His hands-on approach, empathetic and gentle style of consistently nudging forward while ensuring and facilitating progress via funding support and motivation is exemplary. And this has been the experience of all his mentees and students, some of whom are in the audience tonight. He goes on and he says, the cumulative net effect is that he is mentoring a young generation of mental health professionals in the field of global and public mental health for the African region. What a profound and special tribute to you. Finally, Vikram Patel, he must always have the last word, right? He's now Professor of Global Mental Health at Harvard, and formerly was at the London School, and he still has his feet very firmly in India, in Delhi, and sometimes in Goa as well. He read all our minds when he said, you may want to acknowledge the one person who won't be at the celebration, and that's Alan Fisher, as Crick was more than just his protege. Of course we remember Alan tonight, and I'm sure that Alan would have been so proud of your achievements. As we have heard about you from the leadership of the center, which now bears Alan's name, he would really have appreciated your role as custodian of the mission of the public health, of the mission of public mental health, which he shared in his own inaugural lecture in this very room more than a decade ago, and some of you may remember that. And that night I also did the thanks. So, but then in true fashion, Vikram goes on, and he says, perhaps some in the audience may not know that Crick is not only a brilliant academic, but has a streak of the wild side. The sanitized version being that he's a closet surfer and a double bass player. Well, as he thinks he has the last word, I can actually pip that. Because I have it on good authority that one of Crick's latest closet activities is his evolving ability to moonwalk. Credit to you. So to Crick's family, Justine, Sam, Jacob, his dad, Vernon, thank you for all your support for Crick, and for now equipping him with a new skill, moonwalking. That will undoubtedly ensure that Crick's illustrious journey of reaching for the stars that form the constellation of global public mental health continues to gain momentum. And for all that, Crick, we are truly grateful.
You know, Professor Lund, if this was a music function, you will have to do another one. So before we get into that, I suggest that we all join you to have a few drinks and to thank everybody for being here. Thank you, all of you, for having come to this really important occasion. Thank you very much.